Good evening, everyone. So, our first discussion we will tackle all about cerebrovascular disease. So, in terms of stroke, it's more commonly infarction, comprising three-fourths of all stroke cases. And usually, in the infarcted areas will be permanent, and because of the decreased tissue perfusion, it will lead to necrosis. You all know about transient ischemic attacks. So this will last for only less than 24 hours, and they are warning signs of an actual infarction. Among the established mechanism of infarcts, two-thirds are caused by thrombus, while one-third is caused by embolus. So basically, the pathophysiology um, involves the failure of the membrane pumps, which permits efflux of potassium and influx of calcium, sodium, and water. This produces your cellular or what we know as cytotoxic edema. Then these changes in brain water are the key principles on what we see on CT scan and MRI imaging. I've shown this table before. These are the differential diagnosis per age group of ischemic stroke. Now, here are some features in hyperacute or acute stage of infarction. This one involves the MCA territory. So we can appreciate the hyperdense artery sign. If you notice on if you notice on the right side of the brain, you have this hyperdense curvilinear structure representing your MCA. So it's hyperdense because of uh, thrombus or embolus lodged in this region, and there is an associated early edema in this region, the area supplied by the MCA. These are the labels in aspect score, so you can appreciate the area of infarction involved in the right side of the brain and how the normal left side compares with the abnormal right side. On MR, it will be appreciated as loss of flow void. So you can see this is the normal flow seen in the left side, and you won't be able to appreciate that same black structure which would correspond to your MCA. Then you also have the insular ribbon sign. Sometimes this is the only clue that there is a hyperacute infarction happening. So the main thing is to look for which side is involved. So if the patient presents with left-sided weakness, you look at the right side, same as in this patient. So you will be able to appreciate loss of the insular ribbon, and that is a key sign in very early infarction. Now these are just different sequences and imaging modalities that of a same patient that will show us the difference in imaging and what we see per imaging modality. So on CT scan, you will just see a very subtle area. Sometimes it can be missed because, again, the finding is not yet very clear. On T2, somewhat you can see a relative hyperintense region here in the left parietal lobe. Then on the WI, as we previously discussed, it's very helpful in hyperacute stage. So you have this very bright area with signal drop off on ADC. So this constitute the region of the hyperacute infarct. On FLAIR, you can on coronal cut of the brain on FLAIR sequence, you can appreciate the precise region involved in the infarction. Now, in perfusion studies, you can see that actually the area of possible involvement is larger. So this is what you call as the ischemic penumbra. The important thing in identifying the structure, so earlier we established that the infarcted region is this drawn by the black dots, but the white dots um, is a telling sign that this could be the uh, area of involvement if the infarction progresses. So this will help clinicians and radiologists identify what part of the brain they could still salvage if appropriate management and therapy is given to these patients. Again, this is something that you should always remember that a non-contrast CT scan is still the mainstay in assessing emergency cases of acute stroke. So this table compares the CT and MR findings based on the timeline. Um, if you can recall in neuroimaging and in neurology practice, the timing is very important. The the onset of the signs and symptoms is very crucial in helping us identify the findings and at the same time helping the clinicians um, with their management. So try to familiarize the features that appears on each imaging modality. Now there are certain stroke patterns which we can recognize because of our established idea of the homunculus. So if you know which part of the body is affected, then you can suspect which tracks may be involved and you can localize which specific gyri is involved. So one clue also is the vascular territory. If you can trace the blood supply of the area of involvement, then you can also suspect where the possibility of the thrombus or embolus is. These are just some of the more common vascular territory strokes and how they will present. So this has already been taught to you in med school. It's in prior subjects in neurology. So just familiarize again with what areas may be involved. So this is an example of ACA occlusion, MCA, and PCA. Here is another example of a PCA infarct. You can see that the area wherein there's very bright signals on T2 corresponds to the vascular territory supplied by your PCA. Let's now go to hemorrhage. Again, this is one of the things that is important. That's why we order a non-contrast CT. we want to rule out hemorrhage. And most of the time, it's easy to look for this. What could be mistaken is the possibility. An example is here in your choroid plexus. You can have calcifications, which may be normal in certain patients, but hemorrhages occur in certain locations. They are commonly seen in this area, so that can help us rule out or mistake it for calcification. Another thing is to measure the Hounsfield unit since there's a big difference in the Hounsfield values for calcifications and bleeds. Now there is what we call evolution of hemorrhage on MR. Again, this depends on if it's hyperacute, acute, subacute, or chronic stage. So try to memorize the T1 and T2 signals on each stage. Um, to easily recall, it's the mnemonic they say is it's IB, ID, BD, BB, ID. So I bleed, I die, bleed, die, bleed, bleed, die, die. We've also already discussed subarachnoid hemorrhage, so I'll skip this one. You can have subtle cases of subarachnoid hemorrhage, and these patients may present with not so painful headache. So here is a very small intraventricular hemorrhage in the right lateral ventricle. Now, in terms of parenchymal hemorrhages, as I mentioned, there are common expected locations. The most common, especially, is the putamen, then followed by the subcortical white matter, cerebellum, thalamus, and the pons. For AVMs, these are the most common type of brain vascular malformation. Usually the location is supratentorial, so that's another clue um, for AVMs. Now for hemorrhages, this is an example of an hemorrhage involving the basal ganglia in the left. Again, try not to mistake the calcifications in the choroid plexus as for hemorrhages. Now, in this case, in the not so nice image in your left side of your and the right side of your screen, we have rim enhancement surrounding the bleed. So this is typical of subacute phase in hemorrhage. So you expect um, enhancing rim, which represents the vascular capsule. So this is an example of a right frontal AVM. You can see the feeding vessel and the tangled malformation. On angiography of the same patient, again you see these tangled vessels. Then quickly let's talk about how to differentiate between benign and malignant intracranial hemorrhage. So benign intracranial hemorrhage would mean the typical hypertensive hemorrhage or those caused by benign disease entities, while malignant intracranial hemorrhage pertains to those caused by metastasis or a primary tumor. So sometimes it's difficult to differentiate either, but here are some clues, in how you will be able to um, at least or help you in determining if the source of the hemorrhage is a benign or a malignant process, because sometimes the first presentation of these patients is the intracranial hemorrhage. So you will see the area where it bleeds in the brain, and sometimes the mass is obscured by the bleed. So it's important to look at these features so that you'll know, or you might have an idea as to what you are dealing with. So that's it for bleed, no? I tried to make it more concise as well as with the other topics since it's very hard to grasp everything in neuroradiology. So we just take snippets of each topics. I'll try to tackle the more common ones so that you'll have an idea of how they look like.